Here I have with me Dr. Sharat Putta, and the case is of a difficult case in the sense that we have again a hilar cholangiocarcinoma. So let us say how he hilar or obstructive jaundice with hilar malignancy. So let us say how he tackles this. We will decide about the procedure, what to do about procedure tomorrow morning. But this is the diagnostic demonstration. So we have got about 25 minutes to show what we want to show in this case.
My scope is completely anti-clockwise here, and what I find straight away is a lot of intrahepatic biliary dilatation. I'm trying to see if I can trace the confluence of the biliary system. I'm rotating clockwise a little bit. Yeah.
You can show the just the left right junction is blocked.
Yeah, this is the left duct coming through.
Yes. And then it becomes a little bit.
And I'm losing it here.
It goes off.
Yeah, I'm losing it here. It's out of
beautifully dilated segment 2 and 3 duct.
segment 2 and 3, and then coming together here. And then when I try and rotate a little bit more,
Yes,
here,
can you apply color to show that this is the still left duct or it has become the common duct?
I'm not sure yet. I would like to see these ducts joining and then traveling down, but yeah.
It's coming from below.
Yeah.
Yeah, here they are joining here. Can we remove the color Doppler box too? Because this is a beautiful pointer. Because it appears to me that this is the place, that this is the left duct, and you are showing the joining of the duct here.
Yeah, the right duct is coming from below. And
the right duct coming from below.
Yeah.
Okay.
Okay. Now I can't from here. I've used the lowest frequency possible. I mean, are we on 5 megahertz? I can't yet see any mass lesion from this station. Or a tumor causing this obstruction.
What is this? Can you explain to the beginners what do you think is this? Is there the ligaments are a little bit about because there is ligamentum teres there, but not so well. Yes.
Yeah.
Yes. This could be ligamentum teres.
Yeah. This could be the ligamentum teres.
Yes. This divides the left and the right lobe. Yes.
Yeah. I think we are seeing this. This is the left segment, segment 2 and segment 3, and coming through here. I think this is you're probably seeing. I would expect to start to see the gallbladder here. That's the portal vein coming through.
Just beyond the portal vein, I think there is a mass like it.
Yeah, I think just under the portal vein.
Can
you might be. Yeah, just freeze. Yeah, just.
Dr. Vikram,
yeah.
Please again help me.
Yeah.
You know the knobs better. The other way around.
Yeah. Yeah. So, Vikram, we just started by actually demonstrating this gentleman with obstructive jaundice and then this IHBD. And I just traced the portal vein. And yeah,
no problem.
that's the portal vein. Yeah, so I think just below it, we might be seeing the resolution isn't great, but yeah, around about there we might be seeing a vaguely defined hypoechoic mass, possibly. There, it's coming through there. Yeah. And so when I rotate through, I'm looking to see if this is invading the portal vein. I think the portal vein itself is intact. There's no invasion or encasement here. And this is the aorta coming through. And the superior mesenteric artery coming through here. Yeah. So the superior mesenteric artery seems to be uninvolved. And that's the left adrenal that we are seeing. And just checking on the pancreas quickly. So splenic vein, splenic artery. I haven't yet seen the PD, but it's clearly not jumping at us. It's not dilated. I think this is the PD going through. The PD is the waterfall sign falling through the neck. That's a non-dilated PD. And this is the confluence of the portal vein, splenic and mesenteric veins. And the uncinate is across on the other side of this portal vein. Yeah, that is the uncinate below the portal vein. So I need to go to the point of interest now, into the duodenum. Just turn the patient, please. Just turn the patient a bit. Just left lateral. Left side. Left side. Just for me to enter. Just entered the duodenal bulb, but I've just been shown a trick by Dr. Malay Sharma. So I'm just going into D2 straight and upping my knob, distending the balloon a little bit and slowly pulling my scope back. So I see the aorta there and the pancreas appears at around about 3 o'clock, the ventral pancreas. I'm pulling back very slowly. I see something appearing over here, something very vaguely defined and possibly some acoustic shadowing going through there, the hyperechoic structure with a acoustic shadow going through there. Don't know if I'm reading too much into this, but that one there, do you agree, Vikram? Do you agree there's something here? Have a cursor. Yeah, this one here, this one here. Is that causing? It doesn't look like the kidney, this, whatever this little structure here is. Okay, I'm pulling back. Pulling back. I think that's the IVC that I'm seeing there. I think that's the kidney. That's the kidney. So I'm pulling back a bit more. I'm interested to look at the liver hilum, the gallbladder area specifically. Yeah. Yeah, that's just fine. Yeah. Yeah. I think I might have fallen back into the stomach. Yeah, I think that's why I wasn't. Just get back into the diurnal bulb and see if I can get a good view of the liver hilum.
तीनों चीज डालेंगे कॉन्ट्रास्ट मिथिलिन टू
I'm back in the bulb here
सलाइन और हमारे पास वो है वाटर पंप
and
वाटर पंप से कनेक्ट हो जाएगा बस ठीक है और सेटिंग्स 4 और 100 हाँ प्योर कट
so that's the liver hilum. There's a portal vein and the hepatic artery, I think. Yeah. So I don't see the bile duct. I don't see the full stack sign. I'm just finding possibly some excessive soft tissue or a vaguely defined soft tissue mass here, which may be, and this is the liver hilum and the portal vein, that may be obstructing the bile duct at this level. And it seems to be encasing the hepatic artery.
That is a fantastic demonstration.
Yeah. So what branch is this, Dr. Malay Sharma? That seems to be coursing right through the tumor there. This one. So can you elaborate on this anatomy here? I think we're seeing the hepatic artery there.
You have to
Yeah.
follow it all the way.
Yeah.
Because before they start branching, but this common hepatic artery, I would say probably it is at the origin of the gastroduodenal artery.
Yeah.
It's the origin of
टूट गया
the
ना?
common hepatic artery.
टूट गया
Let me
क्या?
enlarge it first.
जो बांधा था
Okay.
Can I have a mic, please? Mic. See, because at this place, this is the mass.
Yeah.
And this mass, the encasing the common hepatic artery,
Yeah.
the partly hepatic artery proper, specifically the gastroduodenal artery at its origin.
Absolutely.
So
Yeah.
it is encasing,
Yeah.
the length of common hepatic artery is around
डाउन
2 to 2.5 centimeter. So in this case, this is a mass we have not been able to demonstrate the CBD lower down, probably you have, but this is involved. Am I right, Vikram? Beautiful demonstration. Now this is the ligament.
Yeah. So I think. Yeah. So this is the whole extent. I'm rotating.
Yes.
I'm rotating through clockwise to anti-clockwise.
The portal vein is encased or not encased?
Portal vein, it's not encased for sure. There could potentially be a 90-degree contact
Yes.
with the tumor.
If I would
Uh,
say
yeah.
that this is the arrow, that this is the 90-degree contact you are mentioning from here
Yes.
to here.
Yes. Yeah.
I will
So-
make, yes, 90 degree from here to here contact. Oh,
I
fantastic,
agree.
fantastic.
I agree.
Means because this is, and this is the tumor, this is the tumor.
Yeah, and I'm also looking for. I'm assuming. I mean, that's where I expect to find the gallbladder. So I'm looking to see if there's any coexistent stones within this tumor. This is the mass, and I'm wondering if that's a gallbladder filled with sludge. Filled with, yeah. So that's, I think that is the outline of the gallbladder filled with sludge. And the mass, yeah, and this is potentially the neck of the gallbladder, where we have the mass. Yeah,
This is the gallbladder. This is the gallbladder.
yeah,
So this is the gallbladder going up to the neck,
yeah,
then going here. Yeah, this is the mass extending from the neck into the CBD, then encasing the hepatic artery and going higher up, encasing the portal vein. Yes, beautiful, beautiful. And this is where you see stones in the gallbladder in this view.
Liney bile and ecogenic.
yeah,
Ecogenic,
we're
yeah.
seeing some acoustic shadowing here, not
Yeah.
as clearly as you would normally find, but I think there is that triangular acoustic shadowing going through.
Now, the only question is whether we can trace this. You have traced this mass above and below.
Yeah,
Yeah. If we trace this hilum, this is above, can it be the bile duct?
I'm expecting to find, when I rotate a bit more clockwise.
Yeah.
I'm expecting to find the bile duct under the probe when I do my clockwise rotation. In the anatomy, obviously a little distorted here.
So in this case, we just, can we get the FNAC needle?
Yeah, we can get an FNA from here. Doppler. Right.
Sure.
I would be aiming at this area.
What needle do you want, Sharath? 25, 22?
22 would be good,
22.
Dr. Maloo.
Okay.
Yeah. What I'm unable to do yet
As
is
you put it a little
to,
bit inside,
yeah,
you can probably see the bile duct coming up. Yes, yes. Now they will come. Yes. Maybe.
yeah, I'll quickly get an FNA and then
Okay.
I'll see if I can trace the,
Taking an FNA.
yeah, yeah.
And then we'll decide. Vikram, you prefer 25, 22 in these cases?
So I would prefer 22 in this case, but that's just my preference. Because the scope here is very much rotated. So the channel is 3.7, 3.8 millimeter. I find 25G veers off the scan plane because the scope is rotated. And the channel is very big, 25 is very small, so I find it wobbles. 22 is more firm, it goes bang, and I can trace it under
Yeah.
vision. But then literature quotes that 25 may be better.
I think when I have a lot of, when you have vascular encasement and a lot of collaterals, I just, as a matter of caution, I tend to use 25.
As I said,
Yeah.
this is the guide.
Yeah,
This fused scope, an interesting feature is visual guide. You see
Yeah.
these two lines and you bring the lesion between these two lines.
So in Fuji system, these lines are actually for 25G needle as you are using 25.
just hold the scope for me, please. I'm using a 22.
No, he's using a 22, but the needles are for, the guides are for the trajectory for a 25G. For 22, it will be smaller. For 19G, the movement will be restricted. Okay. But the scope doesn't know which needle you are using, so obviously the guides remain the same.
Yeah. Okay, we are in.
Hold on. Yeah. Okay,
For
yeah.
biopsies,
Yeah.
for core biopsies, we can use a cheap man's biopsy.
Yeah.
19G. It is
Yeah.
like a manganese
Correct, correct.
aspiration.
trying to fan, but my range of movement is a little limited. I'm all twisted and contorted here.
So for liver biopsy, 19G.
Sorry? Ah, so
And
No,
for
no,
other
Abhinay.
tissues, biopsies.
We'll just,
histology, 19G.
so I can actually, as I pass my needle, I can palpate the softer and the more firm areas of the lesion as I'm doing, as I'm passing my needle in and out of the lesion. I think it's quite an important thing to consider when we are trying to fan or get the appropriate site FNA. We'll just see what we got. Um, I'll get into D2, get in a bit deeper, shorten my scope and see if I can identify the bile duct distally. That's the aorta. Can I get some water, please? Or saline? Yes, please. Yeah. Do we have anything there, Dr. Malay? Yeah, yeah, okay. Okay. So that's the diurnal follow. That's the D2, I think. And we can see the differentiation between the ventral and dorsal pancreas there. Hypoechoic versus hyperechoic. That's actually showing up very nicely in this patient.
Yes, the image is very clean with this scope.
I think I've slipped out
Once you
again.
get used
Yeah,
to it.
yeah.
Once you get used to it.
I've slipped out again. Should we take one more pass, please? Yes, yeah, okay. One second, let me get in. Yeah. Let me get in. One second, hold on. Right, okay. Yeah. Do you think we got the epicenter there, Vikram, with the first pass?
Yes, I think the target was absolutely
Yeah.
bang on.
Yeah. Okay, there it is. No, I'm good, I'm good. Okay. Yeah, let's go. Just a second. Can somebody give me a Doppler just below my needle, please? Yeah, okay, fine. Yeah, thank you. Yes, yeah. Yeah. So this is, sorry, went into too far, but that's the firmer part of the lesion there. That's where I feel it's really firm. So I'm going for that area. I'm trying to fan a little bit, but it's all, the scope is in a slightly long position. Sorry, I fell back. Yeah. Okay, I think that'll do.
Any questions from the hall?
Any
for Dr.
questions or anything else that I need to be looking for, Dr.?
No, from
Yeah.
the hall, any?
So what we've shown here is a vaguely defined mass lesion in the area of the neck of the gallbladder. There is intrahepatic biliary dilatation. The mass is encasing the GDA and the common hepatic artery. And it is in contact, and there is a lot of loss of tissue planes between the portal vein and the mass for a short length. So I think it is we think it is a gallbladder neck tumor, which is probably not resectable because of the arterial encasement.
Dr. Vikram,
Right. Yes,
there is a lot of, worry that we all have going about transvascular punctures leading to bleeding. My question to you is, in your clinical practice, have you, how frequently, or have you actually ever encountered a case of clinically significant bleeding after a transvascular puncture, transarterial or transvenous?
so I never do a transvascular puncture. I don't know about Dr. Sharat can answer. Do you-
I have never done one.
I
Yeah,
never do
yeah,
a transvascular puncture. I think that's
Yeah.
pretty reckless to do.
I think.
Either through the
Uh,
veins or through the arteries, most of all through any collateral.
And I think one important thing which we forget, which Dr. Vikram had elaborated during the previous case, if a patient has a mass and they're in the elderly age group and you think it is malignant, although you don't have an FNA, sometimes you have to subject them to the Whipples, particularly there's a double duct dilatation, or the earlier case, for example, where you have a very difficult FNA.
Absolutely.
Yeah.
So point is that
Yeah.
it is the responsibility of the endosonographer to just keep watching till at least he is convinced enough. So these cases are never done in a rush. So again, apologies for taking 5 more extra minutes in the last case, but that will define the decision for this patient. It's a life and death decision for a patient. 5 minutes is nothing for such a decision.
Yeah.
So one stays inside, one keeps on watching. And then as you watch, things start to get clear. So that's the dictum in US. Watch from two sides in two planes and watch long enough. That is very important. One should never make snap decisions in the US.
And I think it's not the end of the world if we can't get an FNA for a patient. I think we should always look at other means of getting a diagnosis. Thank you. Thanks for
Thank you,
the
Doctor.
opportunity. Yeah, thanks.
Thank you for the very nice demonstration. Any questions
Thanks.
to Dr. Sharat?
So we are coming to the end of the day. We will have the result of the FNAC available within half an hour.